Okay. My dear colleagues, my dear friend, I'm French dermatologist, laserist, and user of VIOL system with radio frequency. Is my name or is your name? Is my name? Your name. Okay. I'm Dr. Ling Ting Song. Look at me. I speak French. You speak French? Si, hein? Merci. Ah, petit peu. Yes, it's really a pleasure. You know, I'm dermatologist. I'm the scientific director of IMCAS since more than 7 years now. And we are so proud to have these eminent colleagues today for this symposium about radiofrequency. You know, it was a very good surprise. When I first time I used radiofrequency more than 15 years ago, with the first one, second device, and then since more than 3 years, VIOL system with the Symposium in France. And we see the progression of the different radiofrequency in time. And probably VIOL makes a break when we compare with the other device. But we know that it's never we have to stop, and we were very surprising by the different indication about this system. You know, at the beginning it was for rejuvenation or scar, but we know that, and probably Sylvian will be the first about pigmented lesion, vascular lesion, and so on. So every drug delivery, many cosmetic delivery. So it's very, very interesting for dermatologists to have this device, this procedure, because it's not only a device. VIOL propose a different procedure to obtain a good result and for our patient in a daily practice. So I'm so proud to have this incredible panelist of doctors from Thailand, from Malaysia, and from Indonesia. Okay, so I open this symposium, and my first speaker is my dear colleague from Thailand, professor, and we will speak about pigmented lesion. Yes, welcome. You need? No, I'm sure. Yeah, about the same.
All right. Thank you, Mr. Chairman. I would like to thank VIOL again and IMCAS to let me have opportunity to share with you my trust study for a new application of the microneedle film for pigment lesion. Okay. And you know that in the past, like he told us, we start with scar and many things with the RF, but we always afraid of complication of RF, like in pigment skin type 4, 5, like this part of the world, because it can produce too much heat and produce inflammation and end up with hyperpigmentation. So to use it for hyperpigmentation is something that almost impossible to think. Okay. I will tell you. So I work a lot. In fact, I become world famous when I start to use Q-switch laser for pigment lesion, melasma, or something successfully, and report in 2008. Okay, I had been invited to Korea a few years ago. They have a special session and let me talk about this. Okay, laser toning, that they call laser toning. And they call me father of laser toning. Okay, now I try to be a father of other machine. It's boring to be father of laser toning for too long. The key for success of hyperpigmentation, okay, the first one is correct diagnosis. Important, okay? So you should have the basic clinical dermatology to be precise enough by eye alone, okay? You don't have much help. Maybe dermatoscopy can help you, but correct diagnosis is important. So if you misdiagnose it, like you are trying to treat nevus of aorta, early case at melasma, you definitely feel. Okay. Second, clinical type, okay, what kind of lesion, and depth of lesion is critical, because now we are using needle that very precise. We can precisely go from the epidermis, upper, lower, basement membrane, upper dermis, and lower dermis. So that's important. Dermatoscopy help us a lot to see better. Okay, oh, sorry. Okay, and if you want to do measurement, okay, we have many small handheld to measure melanins or erythema index. That I use it for a long time ago, because okay, you cannot rely on your eye to say that it is better or not, or rely on the patient, because the patient always said, it's not better, doctor. It's not better. But in fact, there is a slowly reduction. Okay. Skin phototype important, because the melanin load in epidermis is very high in dark skin. And previous treatment, outcome and complication. Okay. And recording is important. Now every case I do I will show you how we work. Okay, later. Okay. We know that when we deal with hyperpigmentation, there are different levels of melanin. Okay, we can have a hyperactive melanocyte, okay? Like in PIS or something, you have hyperactive melanocyte. The new melanocyte come and very hyperactive, and they are melanophase, so it become epidermal and dermal. Okay, hyperactive. Okay. So, and melanocyte is a dendritic cell. You know that epidermal melanin unit, 1 unit melanocyte supply 38 keratinocytes. Okay, and melanosome. Okay, in white skin people, they have less mature melanosome. Okay. But in dark skin, we have more, okay, type 4 or 5 melanosome, and it's packed and dense, cover the nucleus. The purpose of melanin is to protect, okay, our body against UV damage. So that is the main idea for me, why we have melanins. Okay. It's survival, okay, adaptation. And enzyme involved, you all know that it is a basic biology. Tyrosinase, okay, is an important enzyme, TR1, TR2, to build melanin that we have. There are many types of melanin, okay, eumelanin, pheomelanin, but in our pigment lesion, we are talking more about eumelanins. So in the past, we only try to inhibit tyrosinase inhibitor. That is the end state. Okay. That's why we fail. So when you want to treat a pigment lesion, whatever you use, okay, laser, medicine, anything, the target of hyperpigmentation will be 3 locations. The first one is the subcellular melanin synthesis, like using medicine, tyrosinase inhibitor. Melanosome, okay, maturation, okay, and transfer is another target that can be treated with laser, but a different type of laser. Like a light laser toning is for melanin transfer. Melanosome, you can break it with a very short power nano picosecond laser. Cellular level, okay, you destroy the cell. Okay, melanocyte with a dense melanoma, like using a yellow light IPL, okay, or long power laser. You kill the cell, remove it, but end up with a hypopigmentation that need time to recover. And the tissue level, you peel all the skin in the part, like chemical peel, laser resurfacing something in the part. So these are 3 important areas to understand when you treat pigment lesion. In the past, we did not understand much, we just do it. When we first start have laser, we use the CO2 and then erbium. And in dark skin type, we always end up like this. Hyperpigmentation, PIS, or recurrent of lesion and worse than before, or hypopigmentation, mottling, hypopigmentation, okay, like melasma. Then we try to treat it, over-treatment with the laser toning, okay. So number one, we talk about melasma, okay, because it's the number one hyperpigment problem in Asia, okay. You have to concern with the pre and post treatment. Like if the patient had been treated with a tyrosinase inhibitor, okay, you stop the medicine, like you stop hydroquinone. The enzyme that had been suppressed interfere, become overactive, and within a few weeks you can end up with a rebound hyperpigmentation worse than before. Okay, because we only suppress it, the cell still there. Combined treatment like a topic medication now, like topical tyrosinase inhibitor, intradermal, and the one that commonly used now is the tranexamic acid that work at 2 levels, okay, interfere with the vascular, okay, mediators, okay, synthesis, okay, and tyrosinase, okay, activity, and or systemic oral tranexamic acid, which have some potential side effect for long-term use. And energy-based device, IPL, the first one, and RF, okay, insulated, non-insulated micro needle, RF, laser, okay, long power, nano, picosec. Even HIFU can be used if you understand it. Really HIFU, shallow level of HIFU. So do you have many options to use? Okay. So you have to familiar with the system, the technique. We are going to talk about this new innovation. We did really interesting. 3 years ago, I started to interest in this VIOL product, Symposium one, because at that time they don't have the pulse wave that important. Because the pulse wave is a really breakthrough in the technology. The effect of non-insulated needle is produced what we call Dr. Nas, the Korean scientist, doctor, can report this. And it's because it is a bipolar, the electric current run between the needle and produce the reaction, high temperature at the tip. If energy increase, it spread up. So we can control the spot of reaction from very tiny and then go up. So we have a precise control, intra-epidermal. Okay. And if you look closely to what happened, in fact, it produce what we call plasma. In fact, now we are using plasma. It's between the two electrodes. It produces plasma. And plasma have many effects that we still don't know. Yeah. But now we use plasma to stimulate the cell, to destroy, okay, and regenerate the cell. In the past, I used the plasma for resurfacing. Yeah. Plasma resurface, hot plasma, and stimulation cold plasma. It's still available, the technique, okay. But it is a needle-induced plasma. In fact, it is a needle-induced plasma. Okay? It's not only in non-insulated needle, it's not a stupid needle, it's very clever needle, okay. So we are talking about clever needle now. And it have the pulse wave, that is the important asset of the system. Okay, you have seen this curve before. So we can control the temperature around 40 to 50. That is a critical temperature to stimulate change without damage the cell. We stimulate subcellular reaction of cell. So now we can use the RF for subcellular, like using laser toning for subcellular, okay, without it damage the cell. The cell is still there, okay, very precise, okay. The target is water, okay. Yeah, water is highest in blood vessel, conductivity is highest, okay, and upper very high. So it limits the spread of heat only to the target and not going too deep with the pulse wave. That is advantage with other system cannot do this. The heat spread down too much heat down there. This is a parameter that we use, power waves. Okay, power wave 2, power wave 3. You can try it, depend on the depth. And now you understand basic. You can adjust parameter yourself. Don't believe in the parameter that come with the machine. It just moderate for everyone, but some case you have to go deeper. Some case you have to go lower. If you don't understand the principle, you can adjust it. Okay, the depth of the needle, the level of the energy between 4 to 6, okay, and the repetition rate, how many passes that we will do. The patient with the telangiectasia, you can see that you have PW2 and PW2 level. Okay. And now we look at pathology of melasma. This is the classic pathology of long-standing melasma with the photo damage. You can see the hypermelanocyte in the epidermis, hyper pigment in the dermis with the free melanin and melanophore, and dilate blood vessel and solar elastinosis. Okay, so this is the pathology. And melasma now, we understand that it is a photo damage disease. Okay. It relates to photo damage. So if you want long-term remission, cure or not, we don't know. But if you want long-term remission, you have to correct this damage, make it as normal as you can. Okay. When you look closely at melasma long-standing, you can see that the pigment is not homogeneous. There is an area that dark, an area that white. It's not homogeneous. In some cases, dilate blood vessel. Many cases, if it's too long. Okay. So if you can think that if you apply cream, how can you apply only to the dark spot? Avoid the white area. Okay. So the cream is useless for the long-standing melasma. For me, it just make the patient happy for a few weeks, and then it come back. When we look at the pathology of melasma, there is DEJ damage, dermal epidermal junction damage, and this is the critical point because when it damages, the melanocyte drop down and release melanin into the dermis, and will be taken by melanophore, and it persists for a long time, like tattoo. So your dermal melasma or mixed melasma, it's like you have a tattoo. And how can you get melanin tattoo with topical? Okay, impossible. Yeah, even pure cannot do it. Yeah, and this is the abnormal cell. Okay, dilatation of vessel and senescent fibroblast, photo damage. Okay. After treatment, it becomes better, reduce MNIF senescent fibroblast that we did not understand until recently, that we think is a source of many cytokines that stimulate melanocytes to produce hyperpigmentation. So if we can reduce this senescent fibroblast, we can reduce the source of cytokines. Okay. So what Symposium do? It regulates hyperactive melanocyte. Okay. It strengthens this basement membrane. Okay. With the power. Okay. It eliminates the dilate vessel that release VEGF, vascular endothelial growth factor, then induce melanocyte synthesis of melanin. Okay. And it also reduces senescent fibroblast. So it have many different effects. Okay, that even laser cannot do it. even Pico laser window. I show you this video, a brief video. The technique is that you have to be accurate with the needle. You have to press the needle correctly, not too deep, not too low, just touch the skin. Okay, because if you press it hard, you go deeper than you want. You press it, just only touch it more superficial, and you do not get the result. So you have to do it properly, okay, and non-overlapping. If you overlap, you produce too much thermal reaction, and you lost what you want. We want to achieve plasma to destroy each area at a time. You can come second pass, but not stack power. Okay. Just do. Okay. Again, you cover. Now you can do pigment spot only and tracing it all the way, not the whole face. And you can use a different level, deeper needle for the deep pigment. Okay, shallow needle for the lighter pigment. So in one phase, you have to adjust many times. Okay. You have to adjust many times. I did my small study with a refractory melasma, 17 case. Okay. Skin type 3 to 5, using pulse wave 0.8 and level 2 parts with continuous to go deep. Yeah, to regenerate new dermis, we have to use the continuous. So this combination with the pulse and continuous in one session, and post treatment using tranexamic acid with sunscreen. Okay. A segment with by semi-quantitative using Vishia, okay, quantitative vision. Sorry. Oh, sorry. Let's go back. Okay, this is the result of treatment. We measure what we call melanin severity, melasma severity index, and T-angiotic severity index, pre and post treatment. You can see the pre-treatment, okay, MSI, the blue color, okay, is going down. In every case, this is 11 cases, and T-angiotic, okay, index also decreased a lot. So the result, after one section, they did one section, and follow up for 4 months, do one time, and do follow up 4 months. Okay. The MSI score, melasma severity score, reduced 83%, and telangiectasia reduced 78%. No immediate post-treatment complication. The result had been maintained with topical tranexamic acid and broad spectrum sunscreen. Okay. We need longer follow-up and bigger study to complete it. This is a clinical Vishia. You can see the refractory melasma with the hypopigmentation. Improve a lot with reduce in telangiectasia. Picosure cannot do this. I use Picosure also, but I cannot reduce the vascular like this. Only pigment and recurrent is possible, but this recurrent delay for long term. No one define cure for melasma. When no one can define that, so we don't know whether it is cure or not. If no recurrent 6 months, can we say that it is cure? Okay, if it happens again, it's a new episode. Okay, so I would like to be the first one who define cure. Yeah, okay. This is not the case. Okay. And prevention of recurrence is important. You have to adequately prevent destruction of abnormal melanocyte and melanocyte. Like if you do, in the past we use a laser like a Q-switch. We produce too much destruction. Okay, and it recur. Prevention of epidermal hypermelanosis, dermal damage using sunscreen and everything, antioxidant, and the newer like biosimulator. Now we are looking for that. Okay, and when we compare it with other techniques available for pigmentation in the past, energy-based device hyperpigmentation. Before this silver had been tried, I always use the picosecond Alexandrite 755 with the DLA, diffractive lens, focus lens, small spot. It works for epidermal melanosome. It's not good for DEJ. Okay, it's not so effective for dermal melanosome and melanocyte, and it cannot reduce the senescent fibroblasts. What did okay, firm, you can see we have better with the senescent vascular. So now my routine is use combination. Thank you.
Just on time, almost. Jane, okay, come. Jane, it's your turn.
Thank you so much. It was such a great and wonderful presentation by Dr. Nuwat. So my presentation is going to be a little bit different. I'm going to talk about more to acne and also vascular lesions. I'm lucky to talk about different topic because we heard it already from the master of pigmentation in RF. So this is my disclosure. This is a sponsored presentation by VIOL. So the three questions for today regarding acne, vascular lesions, and also microneedle RF in this topic, Silverm X, is why is vascularity is relevant in acne, and then how does RF microneedling can help with it? Because initially I was quite skeptical, or I doubt about using microneedle RF in treating acne, active acne and vascular lesions, because I thought it might be too aggressive for inflammations, and last but not least, to combine it with other treatments. And why it matters in acne vulgaris, the vascular and post-acne erythema? Sometimes I think we got results from desperate measures. Why I say that? So these two patients here, the female patient, she is one of my staffs. She couldn't use any topical creams for acne because it's too irritative for her. And the boy there is my friend's son. So sometimes when you are a dermatologist, your friend starts to remember when you are a dermatologist or an aesthetic practitioners if they are desperate to treat themselves or their family. So she came to me because her son is becoming a teenager and starting to be aware of his appearance. So and he is very non-compliant to teenagers and boys. They are quite non-compliant to topical treatments, and other than that, it is also decreasing the quality of life for teenagers. They want to start exploring what they can do with their lives and to socialize. Having these lesions really gave an impact to his quality of life. He's becoming less confident. So I told my friend that. Because he refused topical treatments, he's non-compliant to oral treatments. So, okay, so we both like quite desperate. So I think I know I have one machine in my clinic. Let's try this. I give you like one treatment for free because you're my best friend, and let's see if you can comply with that. We can, and then I will get the charge for later. So. Before we go into that, the acne vessel axis that we can link it to the use of RF microneedling. First, we know the pathogenesis of acne. There is the propionibacterium, or now his name is Cutibacterium acnes, the bacteria that is that plays the main role in acne, and then also the hyperproliferation of the pilosebaceous units, hyperkeratinization in the pilosebaceous units, inflammation, and also the hyperproductions of the sebaceous glands. So how can we target this with the RF microneedling? And also, if we there is a study that shows actually inflammation has already going on in the skin even though the clinical lesions are not seen already on the skin. So there are also the increase of the VEGF, abnormal VEGF, that can also increase the inflammation that happens in the skin. So if we listen to Ajahn Niwat earlier, that actually RF microneedling can reduce the abnormal vascular endothelial growth factors, and I think this can help with the acne. And other than that, we can also see here, because with persistent erythema, there is an increase in the abnormal VEGF and also inflammatory cytokines, and the bacteria itself, the hypercolonization of the bacteria itself, it can also increase the inflammatory lesions, and then also the production of the sebum can also increase the inflammations. It is inflammatory to the skin. And last but not least, if you hear that I mentioned about inflammations, that is why acne-prone patients, they are also very prone to develop acne scars. And some patients, what is more devastating is not the atrophic acne scars, but the acne scars that has erythema in it. It lasts longer than the hyperpigmentation lesions caused by acne vulgaris. So as we can see here, what can we target with the microneedle RF is it is very convenient using the Silverm X because we can adjust the depth, as Dr. Niwat has mentioned. And other than that, this is like, I think this is the first microneedling that has two actions, continuous wave and pulse wave, that you can actually tailor to your patients. If you are targeting the pilosebaceous units, if you want to be sometimes I can be a little bit aggressive because I want to target the pilosebaceous units, and to reduce the sebaceous gland activity, I will use continuous wave. And then if I want to target the vessels, then I use the pulse wave for the lesions. And I will show you later how the clinical results on my patients. And this is already mentioned earlier, how the continuous wave, other than helping to reduce the sebaceous production, it can also help to reduce the acne scars since earlier stage, before even the acne scars starts to be created on the skin. And the pulse wave, we can use it for the vascular lesions and for the inflammatory to reduce the inflammatory cytokines. Okay, now I'm going to show you about the result of the histopathology. So it is proven already how it can actually target the pilosebaceous units, and also what happened in the microvasculature is it is congesting the vessels. It works similar to the vascular laser, where it will coagulate the vessels. Instead, by using the microneedle RF, what is shown here, the vessels will be congested. And the normal vessels, luckily it is not destroyed, because we also need normal vessels to induce collagenesis for wound healing. So yeah, how can we help with inflammatory acne vulgaris? So the proposed mechanism, by thermal injury, we are reducing the sebaceous activity. By vascular congestion, we are reducing the redness, and also by producing the anti-inflammatory effect, and more than that, it can have a dermal remodeling. And there are a lot of studies have been published already about using the microneedle RF for treating acne vulgaris. Okay, now let us see the studies that has been published already. So this is the study in female and male patients. So as you can see here, they got 2 sessions of microneedling. And in this patient, we can see that the lesions are improving very, very nicely. And the interval is 1 month every after 1 treatment. So Because I saw these publications, I read a lot about the microneedle RF in treating acne vulgaris, and I have desperate measures, and I was also desperate that time because the patients refused topical and oral treatments. So now I will show you some real-world case series, and lucky I used the skin analyzer Quantificare to record the pictures here, because yes, I agree with Dr. Niwat, we need pictures, photographs to show our patients is the treatment gave any result. So this is my staff female, 26 years old. As you can see, after 2 sessions, so I gave her 2 sessions of Silverfirm X only, microneedling. For her, I used the pulse wave PW2 and PW3. On her active acne, I use a PW3. So you can see that she only used sunscreen because her skin is very, very sensitive. And what bothers her a lot is actually the post-acne erythema that you can actually see. It is very prominent on her lower face area. And after 2 sessions, I can really see that her post-acne erythema is improving. And not only that, her skin's texture is also improving. Also, the enlarged pores. Yeah, unfortunately, the picture is not too clear, but I hope it depicts the result. And also, you can actually see the post-acne erythema is reducing very, very nicely. And surprisingly, her acne vulgaris is not easily exacerbated, even though in her period cycle. And this is another desperate major patient, my friend's son. So I want to see how is the result, because I promised her, okay, I give you one-time treatment for free to see how your son can comply to that. Teenager boy, they are afraid also of pain. So he can actually tolerate the pain. And the result was amazing. Only by one-time treatment, you can actually see that the redness is improving, the acne vulgaris is improving. However, he had to use quite a lot of hydration moisturizer on his skin. And you can actually see here from a closer picture that the acne vulgaris is improving, the oiliness is improving, and the post-acne erythema, one thing that is bothering, is improving very nicely. And this is another patient for her. She couldn't come regularly to our clinic, so for her treatments, I also combined with topical treatments, and you can actually appreciate that the post-acne erythema is improving, and also acne vulgaris is also improving on her. And this is another patient, male patients. What I like is that the pain inflicted by this machine is really, really low, so it is very tolerable. And this patient here, so 1 month apart, you can actually see the redness is also improving for him. He has a problem with the redness-prone skin. And you can actually see also from the lateral view, very nice improvement for his redness. And for him, he only used moisturizer and sunscreen. And last but not least, this is the last patient that I'm showing about how actually melasma has a very close relation to increased vascularity. For this patient, I advised her to take oral tranexamic acid, but she refused. She didn't refuse, but she couldn't comply to take it like regularly. So she said like, oh, I keep on forgetting, I'm tired, and so on and so on. So what I did to her is that, okay, so let's try do the Silverfirm X on you, and let's see how we can improve your melasma. And as you can actually see on her, the improvement of her melasma is also can be seen by the improved vascularity of her lesions. You can actually see from the closer look how the melasma and also how the redness is also improving. And I want to show you also not only the melasma, not only the vascularity, not only the skin texture, but we can actually see there's a slight improvement on the skin laxity on her her face looks more tightened. And with that, I think with pulse wave RF microneedling and also continuous wave RF microneedling that we have in Silvermax can really help in different kind of skin problems in our patients, from melasma, hyperpigmentation, and also vascular problems that is very related to pigmentation these days. And I think also by strengthening the barrier function of our skin, it can also help with our acne vulgaris and vascular lesions in our patient. With that, thank you very much.
I missed the microphone. Was the last speaker, but not the least? Okay. And you conclude. You have 15 minutes.
Right.
No more.
Okay, no problem.
Where is my timekeeper? She's lost? Ah.
It's here. All right. So we heard about how this whole thing improve our skin, and my topic is managing melasma better by working on the extracellular matrix. So this is a sponsored session by VIOL. We talk a lot about skin quality, and today we saw how we can improve skin tone evenness by reducing the pigmentation and also redness. Of course, with improved skin quality, you get skin surface evenness, wrinkles, fine lines, pores gets better, skin firmness, and also skin glow. So the thing about skin is that it's everything that we see on the outside translate to the inside. And basically, a lot of times when we look into what really determines the skin quality is the ecosystem in there. And what we know is that we always think that hyperpigmentation itself is the pigmentary problems. But if you think carefully, what really pigments does to our skin and our tissues, they are actually part of the defense mechanism. Pigments are there to protect our tissues from further UV radiation. They are there for a reason. And therefore, when we look into what really happens to those who have, like, for instance, acne and melasma, there's something going on inside the skin that is telling us to produce pigments. And we talk about extracellular matrix. We used to think that it's only like a fish tank with full of water, and our cells are the fishes in there. But when we really look into what really extracellular matrix looks like, there are fibril networks that builds up the whole tissues. And this is a video done by a famous plastic surgeon from France. He did an endoscopy 30 years ago, looking into these connective tissues and how they behave. And one of the things that really interesting about his finding is that this tissue is not static, it's forever moving, and this structure actually determines how our structure behave. Because when you actually peel up the skin, you can see over there, the skin with all the blood vessels on top, and it goes down, the connective tissues connects everything together. And one thing that we realize is, in fact, our tissues is not when we see during cadaver, because cadaver are dried specimens. They are post-mortem. And most of the time, you don't see these tissues anymore. And in fact, if you look into real human being, there's a lot of empty space. We call it interstitial spaces. And there are clusters of cells. Blood vessels travel through our connective tissues and supply blood to the cells through them. And the cells communicate with the surrounding tissues, the surrounding environment through these connective tissues. And everything we see in the skin, for instance, inflammation, is because there are some inflammation in these connective tissues that block energy transfer, blood supply, lymphatic drainage, and therefore they build up a lot of abnormal blood vessels on top to resupply on the surface. And that's why we get a lot of erythema, and with that, you bring in a lot of immune cells that stimulate your melanosomes to create melanocytes to create melanosomes, give you a lot of melanin to protect the skin because there's a SOS call from your connective tissues. And this fibril network, the ECM, is not fixed. It's constantly static. As you can see here, it's constantly moving. And every time it moves, it doesn't go back to the same position anymore. That means it's constantly finding a new equilibrium. And with a lot of times when we actually look into these connective tissues, it connects the skin to the fats, to the aponeurotic fascia, and into the muscles. And when we look into the macro scale, it looks as if it's a supported tissue. But in fact, in the molecule scale, these all connective tissues transfer to the integrin into the cellular level where it works, it connects to our cytoskeletons and then connect to our nucleus. Therefore, everything that we produce from cells comes from connective tissues, the ECM. And with aging, what happens? This cycle of renewing these connective tissues actually hampered. So we have glycation due to high sugar content, and also UV radiation causes these connective tissues to become dysfunction. And because of this dysfunction, that we start to see what we call a glycation of our connective tissues, and it becomes hardened. And this is where we see erythema, and then end up with PIH, hyperpigmentation, and of course we live in a land where we get a lot of sun exposure, and what happens is you get melanocytes hyperactivities, you have the senescence of your sebocytes, your senescence of your fibroblasts, and of course you create a lot of abnormal blood vessels because your connective tissues, your ECM, is no longer healthy. And this is a vicious cycle. When your ECM is not healthy, the energy and the signals doesn't go into the cells. The cells felt that altered mechanotransduction, and what happens is starts to secrete a lot of cytokines trying to ask for help. But this cytokine sometimes is not helpful because it actually causes more damage to your connective tissue, your ECM, and this becomes a problem. And we have to know, because in the past we think that if you give them stem cells, if you give them cells, you can actually improve the ECM. But this study shows that if you use a young ECM, a young cells, and you put it in the old ECM, the young cells get older. But if you use an old cell and you put in a young ECM, it becomes younger. And why am I talking about this for Symposium? Because this is a device that uses pulse radio frequency. This is very different from continuous radio frequency because it vibrates. We look at the connective tissue earlier. One of the things that allows these connective tissues continue to be healthy is vibration. That's why electromagnetic field works. That's why low-level light energy or light therapy works, because these kind of vibrations help these connective tissues to be healthier. And this is why we see Symposium does so much different from all other microneedle radio frequency. It changes the basement membrane. What does it made from? It's type 4 collagen. Somehow, along the line, it allows our type 4 collagen to become better. And why do we get back the reed ridges? Because our dermis improve. And why so? Because one of the things that we know about hardened connective tissues is dehydration and hardening of these connective tissues. Pulse radio frequency helps us to shatter and allow this elasticity to happen. And therefore, not only we see improvement in terms of the fibroblast activities, we also see improvements clinically in terms of melasma, redness, hyperpigmentation. We talk about using lasers. I also use a lot of lasers in the past, but in the end, what we see with patients who actually does lasers is that you are not fixing the root cause. In fact, you are taking away the only protective mechanism that your body is trying to protect your skin. The melanin are there to protect the skin. Why are we taking away the umbrellas that are protecting from further UV radiation? And somehow, sometimes if you get very sensitive skin, if you actually do pico lasers, you can actually make things worse. This is PIH due to, and even this is skin toning. With very, very low energy, you can still stimulate them. And of course, just now we heard from Professor Niwat that if you overdo them, you destroy the ECM because energy, sometimes too much of it, causes fibrosis of your ECM, and you get things like you don't get enough supply to your melanocytes die, you have hypopigmentation, you get areas of very irritable area, you produce more melanin to protect, thinking your condition is worse. Therefore, it is important we look into what we can do. I think in the earlier days where we only rely on creams, sometimes we see results because those are early melasma. Those are very, their ECM is still very intact. A little bit of creams, a little lasers helps. But unfortunately, a lot of patients who come into our clinic, they are moderate and severe melasma. Their ECM is all fucked up. And all you do when you do lasers is you actually make it worse. And therefore, I think by combining things like to improve your ECM helps. On early days when we only use pulse radio frequency. This is early, I started using Silvermax in 2017. And the first time I tried it, I wasn't too impressed about the pigments because, yeah, it gets lighter, but our patients doesn't want to go home with just lightened. They want it cleared. But one thing I was very impressed was look at the skin quality. This is after one time of pulse radio frequency. And it's amazing. You see the skin glow, you see skin firmness, you see reduce of redness, you see reduce of hyperpigmentation. Again, these are cases that we kind of see, there's something different about this technology that gives us something that is impressive. And when we started to combine with lasers, this is where we get good results, even for those with hypopigmentation. I think by improving the ECM using pulse wave radio frequency, we can see the skin quality improves, the hypopigmentation gets better. It's a better management of melasma because this patient doesn't come back with more PIH, they get better. This is a patient who actually did IPL in the beauty salon, and then for 4 years, the pigments never get better. So with pulse radio frequency, she stays 2 hours away from me. She comes every 2 weeks to get treatments, and this is what we get, improvements of this pigmentation. And again, we see reduce of pigments and redness. We see improvement of skin quality, even though those who are very sensitive to lasers, and we see patients getting better quality of life. Not just because the redness and the pigments go away, but because their skin quality gets better. They look younger. We reverse the wear and tear in the ECM. That means we are improving the extracellular matrix. They look younger. They actually reverse aging. And this is what we want to achieve. Because in the end, our main goal is to make our tissues healthier again. With that, thank you very much.
Any question? Yes, my friend, you have the microphone, please. Thanks, my dear colleague, for your excellent talk.
Okay, hi, I'm Diki, dermatologist from Indonesia. I would like to ask very simple questions actually regarding this vascular relations and the pulse RF, because it's very interesting to know that does effect on the vascular itself. I use some other microneedling RF devices, but I also have the vascular laser. So this is my questions. When do the vascular relation should fall for the RF pulse, or when we use the vascular laser? In my setting clinic, I'm using the PDL, but I also used to have the long pulse laser. Or can we both use those devices at the same time? Thank you.
Yeah. Okay. Since I'm the one discussing about the vascular lesions, yeah. First, of course, I don't have the PDL in my clinic, so I think this really helps me with the vascular lesions, and I think the mechanism is kind of like different. What we can see is that, according to some studies, it shows like there is not only the congestion itself of the vessels, but also there are some immunomodulation effect of the pulse wave from the radio frequency. And if you want to use it at the same day, I don't think I would really recommend it. That is my take on it. But I think, yeah.
Yeah, so I also use, I have a few vascular lasers in my clinic, and I also use yellow lasers as well. So the early days, when we talk about abnormal blood vessels for melasma especially, I think when we use things like long pulse lasers and sometimes energy-based devices that create a lot of heat, it not only did not make the melasma better, but it actually triggered it more. We actually see worsening of melasma using those. And I think that really brings us down to yellow laser, where we think the sort of damage is gentle. But then again, it's low, and sometimes it still doesn't fix it. And somehow with pulse wave radio frequency, it doesn't cause too much of damage. In fact, it's all about restoring the ECM. And therefore, when we see those abnormal vasculature that is more on the mild, let's say it's due to erythema, rosacea, or that's due to this vascular melasma, pulse radio frequency seems to work much better because you don't have the side effect from the lasers. Whereas if you have bigger blood vessels, for instance, you have spider vein and stuff, unfortunately, I think if you want fast results, you probably have to still use vascular laser. But if you use vascular laser immediately, sometimes you get scar because your ECM is not healthy. You burn them, you create more scarring tissue, they have fibrosis. So what I suggest is perhaps you can use pulse wave radio frequency to do a few sessions, improve the ECM first, let them be healthier, then you use your vascular lasers, and that works even better. You want to?
Yeah, I have a yellow laser, KTP, PDL in my office, and BBL also, and I mix both. But you reduce the energy. You have to, the setting is most important. If you use alone each laser, maybe you can have a higher energy. But if you want to combine, it's like a house. If you want to accumulate too much energy, your risk is to have too much complication. So it's always a balance between the mix between two devices with different target. But totally agree that all combination works, but in which kind of procedure you want to introduce, and you have to speak your patient. You have time or not? You want one session or few sessions? Why? To evaluate the risk of the complication. Because the laser, the radiofrequency, they have no brain. You have the brain to decide in which kind of procedure to decide. So we mix both. Laser or non-ablative fractional laser, radiofrequency to stimulate, and it's very important for about the matrix, because the matrix is a engine. Without matrix, around the matrix, you have vascular, you have pigmentation on many things, cells. So it's very important to reinforce. And the good thing that we discover that radiofrequency, even you don't have the target like a laser, is very interesting to reinforce the junction. And we know with aging skin, the junction is not so good. So to reboot this junction, epidermal and dermal junction, you reinforce your skin. You know, it's always the same. If you want to prove something, do it for medical indication, for skin cancer, to prevent skin cancer. If you can prove something in a medical indication, that means it will work for anti-aging or just rejuvenation. We don't have, as a dermatologist, when I have some new device, I say, can you prove something in a medical indication like melasma? If it works in melasma, that means it's a skin disease. Probably you can prove that you have can expect some result in rejuvenation, because you have so many procedures today to regenerate, to stimulate collagen, many things. Okay, prove something in a skin disease indication. If you can do that like vascular, that means it works for the rest of the other indication.
Let me add something, because I start to use a long pulse before using a very short pulse, nano picosecond, and then in the past, if we try to do skin rejuvenation and reduce vascularity, very superficial, we use what we call laser genesis technique, using the 1064 in the yak with 300 microsecond repetitive, non-touch, no cooling. Okay, some companies still make that machine. Qtera still make that machine. Qtera. So we did what you can. At first, I use it only for rejuvenation, but later I found that with the melasma, I combine with the Q-switch, okay, with the nanosecond pulse, big spot size fat beam, repetitive. The result is better than Q-switch alone. Okay. So I always do that. Okay, combine nano with my 300 microsecond pulse, but not longer pulse. Okay, to do the big vessel, usually we do not do that because it can damage the skin more. With the pulse dye, I also use it, but stop using it because in a very dark skin, the pigment in the epidermis, okay, absorb a lot of energy, 585, 595, okay, and only part of the energy going down deep enough to the level that we want. So, and the machine is complicated and to maintain and expensive to run. So I stopped using powder dye long ago. After I have a silver now, I change it to pico and silver. I believe this combination treatment is the best energy base, but we can add the other biostimulator. Now I'm using a PN, polynucleotide, as a routine after treatment of melasma. So the result is faster and better result. Okay, and you can use it for maintenance for long-term PN without side effect.
Okay, you know how to use a procedure. It's like life. Alone, you go faster. Together, you go further. So it's not me. It's the boss of Apple. Okay, so we end this session. Thanks to VIOL system to help us and to help the foundation also to promote the IMCAS Foundation is very important for us. And, you know, we create a foundation 2 years ago now, and we need money for everyone, you, me, laboratory, and we have, we help a research center for new concept, and for today we have some focus on photo protection on young person. We compare different exosomes for the future, so on adipocyte and senescent cells. So we need money, please. If you have some $10, $1 million, you can help us for, not me, IMCAS Foundation. Okay, thanks a lot to end this session, and thanks to my dear colleagues. Thanks a lot.